Hello, everyone, and welcome to the Immunotherapy Treatment Chapter launch as part of the Myeloma Crowd Community Program by HealthTree. My name is Audrey Burton-Bethke, and I am the Myeloma Crowd Community Manager. Thank you for joining us today as we discuss COVID-19 vaccinations, myeloma, infections, antibodies, and all of that with Dr. Mike Thompson. We're going to be learning about how the COVID-19 vaccinations have affected the myeloma community, as well as other potential infections and antibodies that myeloma patients are dealing with in their journey. This meeting will be moderated by Jenny Ahlstrom, who's the founder of HealthTree and the Myeloma Crowd. The presentation will be by multiple myeloma expert, Dr. Mike Thompson from the Aurora Research Institute in Wisconsin, whom Jenny will formally introduce in just a few minutes. This meeting will be recorded and sent out to all registrants 24 to 48 hours after the presentation has ended. Jenny, the time is now yours.
Okay, thank you, Audrey. So I want to first begin by thanking our sponsors, without whom this event, we could not do this. Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. Now, as Audrey mentioned, today's topic for the launch of our immunotherapy treatment chapter will be vaccines, COVID-19, and myeloma. To me, this new chapter is an exciting one because we have an explosion of immunotherapies in the myeloma space. So with all that coming up, we thought it would be important so that you understand all the different things about immunotherapies. But a more pressing topic right now is still COVID-19. Unfortunately, or fortunately, now that we are getting COVID-19 vaccines. So with these vaccinations, I know a lot of us in the myeloma community have a lot of questions about how it will affect us. I think on our roundtables, we get these kind of questions all the time. Dr. Mike Thompson will present this today, and we'll have a Q&A session at the end of his presentation. So if you have questions, you can see the Q&A at the bottom of your screen, type it in, and we'll get to that about halfway through the meeting. Now, before we get started with today's call, I just want to share a few important things. The first is the COVID study inside of HealthTree. So we want to learn more about how myeloma patients are being affected by COVID-19. Back in April and May, we ran part 1 of this study and 1,300 patients joined. We're now running part 2 study now that vaccines are out and being used, and the results will inform investigators like Dr. Thompson about COVID and myeloma. We have almost 800 patients taking part so far. Our goal is 1,000, so please consider joining this easy study today. And then the second thing I just want to mention is our upcoming roundtable this Saturday at noon Eastern, where we'll be talking about BCMA-related treatments and other targets. So why are all these treatments targeting BCMA, and what other targets are of interest? So now an introduction. Dr. Mike Thompson is the medical director for the early phase cancer research program at the patient-centered research at Aurora Research Institute. He is an active clinical researcher whose interests include hematologic or blood cancers like lymphoma, myeloma, leukemia, and MDS. He's also interested in developing new treatments for all cancers, particularly early phase 1 and 2 molecular biomarker-driven clinical trials. He's extensively published and serves as a reviewer for multiple scientific publications. He's also a Twitter and social media master, launching the Myeloma Twitter account. I've never seen anyone tweet so well or so fast. He's an amazing individual, as well as a very adept researcher, and he sits on the Myeloma Crowd Scientific Advisory Board. So Dr. Thompson, thank you so much for all you do for us all, and we look forward to hearing your presentation today.
Thank you, Jenny, and thank you, Myeloma Crowd. I'll see if I can share my screen here. All right, can you see that okay?
Yep, we can.
Okay. All right, so I have been collecting information about myeloma and infections for many years, and we've done some studies here at my institution. And I'll get into a lot of things, which when I was on a panel a couple of years ago here in Wisconsin, we had a big myeloma meeting led by Dr. Hari and with Natalie Callender from UW-Madison. And he suggested I do a whole section on it. And a lot of people were kind of blown away by the information, especially when you look at the historical context. So I'll try to do that, and I'll try to leave time to have questions and answers, but there's going to be a lot more questions that we still don't know things than for anyone, but I'll try to do as well as I can. Here's my COI. I'm involved in a lot of drug development with companies, including myeloma, most notably with Takeda and the Multiple Myeloma Registry, which I'll talk about later. I'm also one of the reviewers for Up to Date on myeloma. So here's some of my background. I've worked with lots of great people in myeloma, and I won't go through all this because Jenny already gave me a glowing intro. So like I said, we're going to talk about myeloma as a cancer of the immune system. I'll talk some about patient-reported data. This is from HealthTree, which Jenny has been kind enough not to remind me we still need to write up for manuscript. I'll talk about antiviral, antibacterial, and PJP prophylaxis, vaccinations, and COVID-19 and myeloma. So myeloma usually involves the expansion of one type of clone, and other immunoglobulins can be reduced, called immunoparesis. And treatment can also reduce immunity. The most common cause of multiple myeloma death is actually infection. And this is some references going back from 2004. Everyone knows Bob Kyle and Dr. Vincent Rajkumar in New England Journal of Medicine. So, like I said, it's an important cause of morbidity and leading cause of death in myeloma. Other groups have found this, including there's a UK study, which is done over about 2 decades, found that in that earlier data, so this is kind of older data compared to now, 10% of myeloma patients died within 60 days of diagnosis. Infection and renal failure were the main causes of early mortality, and all patients should be considered high risk of death during induction therapy. We'll get to that a little bit later. Early mortality remains high, but is improving. This is Dr. Kumar published something in 2013. But Dr. Rubenstein, who I was on the webinar with right before this, showed at the last ASCO meeting that patients that are hospitalized have a higher 90-day mortality rate than those that are not hospitalized. So I have a number of Twitter threads using MMSM as a hashtag for people to track things. And so you can look at that or try to find these threads. But going back to really 1980, where Dr. Lazarus talked about pneumococcal vaccinations and the response, so the antibody response to vaccination. And this was also looking at IVIG, but 1980, that was a 14-valent vaccine. And I was surprised several years ago when I was asking some questions about infection and myeloma, why there wasn't more data. And there's been really many gaps, but really in the last, I'd say 5 years, there's a lot more data coming out. Other people are getting interested in this area. So this is a study that shows that some different types of infections myeloma patients are at risk for, including bacterial. So you, of course, know about pneumonia, and septicemia is infection in the blood causing organ dysfunction. And then meningitis, HR is hazard ratio, so about a 17-fold increase in risk. So some people have asked if myeloma patients should get meningitis vaccinations. And even though the hazard ratio is so high, the absolute numbers are low. But, we suggest kids that go to college get meningitis vaccines before they go to college, or people in the military or other close-in situations, even though the absolute numbers for them are low. So I think that's an open question. And of course, people know that herpes zoster or shingles is very high risk, and influenza also has a high risk as well. And this is just sharing some of that in a different table form. So some patient-reported data. So before we get into some other studies, what do patients say? So this is from ASCO 2020. So it's our e-abstract. And we looked at patient-reported information from HealthTree with Jenny and Mr. Sweeney, about 500 patients. So it varied a little bit because people could answer differently. But both influenza and pneumococcal vaccines were fairly high in the self-selected cohort of volunteers. most did not receive the anti-zoster vaccine, but a few got the live vaccine, which you're not supposed to do. And antiviral prophylaxis was common, but not universal. And anti-PJP or PCP and levofloxacin use were reported by a minority of participants. And using this online portal, as Jenny said earlier, they're using it for COVID and other things. It can help for hypothesis generation. So this doesn't show us, in a randomized population if these things are useful or not. And I'll show data later on looking at some of that in a global population. So for antiviral, shingles occurs in a very small percent of people who are any dose of antiviral prophylaxis. And there have a couple of studies been looking at this. I did an informal non-scientific poll. This is back almost exactly a year ago, and to see what people use. And most people in this N of 60 response rate on Twitter said that they use antiviral prophylaxis alone, and some use vaccination, and very few use vaccination alone. So we don't know the added value of the Shingrix recombinant zoster vaccine in patients with heme malignancy. It probably doesn't hurt anyone, but I don't really push my patients to do it. And if they want to, that's fine. But I do suggest that everyone stay on long-term antiviral prophylaxis. It's cheap, really no side effects, and I think is very efficacious. So antibacterial and PJP, this is a study from the UK, and it was an abstract in ASH 2017, later published in Lancet Oncology in October of 2019. So levofloxacin is an antibacterial, used to be used a lot more for pneumonia. One of the side effects can be Achilles tendon rupture, especially in older patients. So it's kind of backed off using this type of drug called quinolone. But they found a hazard ratio of benefit for mortality of 0.66. So if that was a myeloma drug, that would be highly impressive, but as antibiotics. So this is 12 weeks. And then Bactrim, which is an anti-pneumocystis or pneumocystis jejuni prophylaxis, had a hazard ratio that was also impressive, 0.52, p-value of 0.9. And this is over 977 patients over multiple sites in England. However, others have said that the call for universal prophylaxis in these patients is premature, and a number of people in the United States have suggested that there are differences between what we see in the UK for the treatments people are getting and maybe other supportive care versus in the US. And there's questions about long-term antibiotic resistance or getting things like C. difficile diarrhea, although none were seen in the study. They looked for that. So I was, when this first came out at ASH and then in publication, I was using it much more. I've kind of limited my use more, but some of this data has been helpful. One of the drugs that I was helping to develop was venetoclax in T11-14 myeloma patients. And some of these prophylaxis measures are used in studies like that after the Bellini study. So for vaccinations, this is unfortunately not an open access article, but I can get it to people if they need it. It was a review article in clinical lymphoma myeloma leukemia, and the first author is the resident who was working with me at the time, Antoinette Alamu. And there's a whole bunch of, I'm biased, but I think really great information going through, including a historical timeline of studies and what the relevance of those were from 1980, then the jump to 1994, 2002, and then up through about 2016. We are working on updating this. There's been a lot of changes since then, and we need to update this with a lot more information, including about COVID. As part of a series of different studies, we had a review article, and then the same resident worked with me to look at what we're doing as a baseline in our health system. So Advocate Aurora Health, or at that time it was Aurora Healthcare, is the largest health system in Wisconsin. We see about 25% of the new cancer diagnoses. And we want to see what the vaccination rates were. Just a very simple question. And we did this through the electronic data analytics and found that 58% of patients had pneumococcal vaccination in the past 5 years. And for influenza vaccination, it's trickier, right? Because it's different every year. So 15% were optimal, they got it yearly, 52% got some vaccinations in the last few years, and 33% got none. There were a lot of hospitalizations, and there was a lot of money spent on patients that were hospitalized. When I ask people at other health systems what their vaccination rate is, they say 100%. And I think that's likely not true. I think people that are transplanted, everybody gets on a vaccination protocol afterwards. So I think that might be some confusion is after transplant, when you're revaccinating people, you may be very close to 100%, but in the general population, including people that aren't transplanted or after they've gotten revaccinated, I have not really seen these numbers presented largely, and that was the impetus for me pushing for another study, which I'll talk about in a little bit. So I think we already talked about that. So this is the study with HealthTree, again, looking at vaccination rates, and clearly not at 100%. You can see, there's still like a third of people not getting pneumococcal vaccine, and 11% of people getting only 0 vaccines. And if you group, the suboptimal, actually for flu, it's pretty good for that cohort in here. And then for the prophylactic regimens, there are some variability. This was looking at vaccinations through the Takeda study and looking at global vaccination rates. And we found that lack of vaccination, this is ASCO 2020, so I'll show more current data, correlated with infection, hospitalization, and death. And we are currently updating this for our numbers to update a manuscript. But here you look at influenza, none, it was, around 50% of people had no flu vaccine. So this is, again, globally. Pneumococcal, it was over half the people weren't vaccinated. So this was updated at the European Hematology Association meeting in 2020, where we did something called multivariate analysis. So vaccination can correlate with other things. So we found that it was significantly impacted survival when adjusted for age, region of the world, and ECOG performance status. This data will be updated, or actually it's an encore abstract, but at HOPA, which was supposed to be in Portland, Oregon, that will be next week. And we have a manuscript in preparation. So this is looking at influenza vaccination here in the last 2 years, and pneumococcal vaccination in the last 5 years, and then whether people had optimal or not, and looking at hospitalizations, ER visits, ICU admissions. And I'll go through this more formally coming up here. So this is from our EHA abstract background. We talked about some. We also looked at healthcare resource utilization, which, as you can imagine, various other people are interested in, especially hospitals and insurers. But this was over 4,000 myeloma patients from 15 countries enrolled up through 2019. And this was not an original part of the study. It was something that I suggested. And at the time I suggested it, not everyone was really clear why I wanted this, but we got it added to the database and collected it. And it's, I think, been very valuable, especially as people are really thinking a lot about vaccinations in hematologic malignancy patients, and especially myeloma patients. So back then, we looked at patients with influenza vaccines and pneumococcal vaccines by region. And this is just looking at a map, and the trends over time aren't necessarily showing increases, but you can see in some places we didn't have very large numbers, like in Latin America, but Asia, the vaccination rates were quite low. And interestingly, vaccination rates were higher in the US than Europe. I wouldn't have thought that, given a lot of socialized medicine in Europe, I would have thought the vaccination rates were higher. So this is a busy slide, but we're looking at the patient demographics. So, very thoroughly looking at age, gender, race, the revised ISS stage, areas of the world, in order to make sure we were not conflating things. And this is more. And look at bone lesions, hypercalcemia, renal impairment, anemia. So the CRAB symptoms to see if they correlated. And then we did a univariate analysis, which is looking at one variable. And then really the most important one is looking at multivariate. So I won't go through these multivariate analysis. And we found on multivariate analysis that vaccination status, for those that had that available, influenza and pneumococcal status significantly impacted overall survival, even when adjusted for age, region, ECOG performance status, ISS stage, cytogenetics, and CRAB criteria. So in the US, the hazard ratio was 1.52, pneumococcal was 0.87. Europe, it was near 0.4. And we'll get back into some of the confusing part with the US a little bit here. So this is looking at all of those different characteristics. And table 3 is showing deaths due to infection by influenza and pneumococcal status, showing that infections in general, and then broken down by type, were statistically significant with differences between those that were vaccinated and those that were not. And deaths due to infection where the status was known were US 7%, Europe 15%, Latin America 20%, Asia 40%. This is looking at health resource utilization and table 4. So patients who did not receive the influenza vaccine had numerically higher rates of hospitalization and hospital admission due to infections, including pneumonia, compared with patients who received optimal or yearly vaccinations. The overall rates of ER and ICU visits were higher in the optimal versus no influenza vaccine, but the rates of ER and ICU visits due to infections were similar or lower in patients with optimal or no influenza vaccination. And one thing that can complicate this, because we didn't necessarily include the timing, is at least in the US, many patients that are admitted, so let's say you have myeloma, you're admitted for neutropenic fever, you're given antibiotics, you're getting better, often before discharge, they'll vaccinate people. So it's a confounder that people that, and that's what we found with our data when we looked at it at Aurora, is we didn't see a difference. And in this global database, we didn't see a difference in vaccination in the US. And part of that might be because of that phenomenon. So more health resource utilization. So the vaccination rates were low and varied by region. The US and Europe were the highest vaccination rates, the lowest rates of deaths due to infections. So this might be important for that UK team study. Asia had the lowest vaccination rates and the highest incidence of deaths due to infections. And vaccination rates in each region appear to correlate with regional variations in myeloma drug availability. Racial and other disparities should be investigated in relation to vaccination access. And in a post-COVID-19 world, the role of infections in cancer will become increasingly important. Vaccination status for both the flu and pneumococcal vaccines was an important prognostic factor for OS and multivariate analysis overall and in Europe, but not in the US. And univariate analysis showed that patients had poorer survival if they don't receive vaccinations, but again, not in the US. And patients who did not receive flu vaccine had higher healthcare resource utilization, including higher rates of hospitalization and hospital admissions due to infection. And this was similar in pneumococcal patients. So one thing that could be happening, besides what I said about people getting vaccinated once they're admitted, is if the overall vaccination rate of the US is very high, that there could be herd immunity, that there's not as much of a benefit for myeloma patients in the US. So this is one database, and I think we really should look at this more, and in other databases prospectively, including in clinical trials, especially if some of the variation in survival could be due to vaccinations, that may confound some drug development efforts, especially, I don't know if people know this, but many drugs that are going for registrational FDA trials are done outside of the United States. So since those populations may differ, if you only have 5 to 10% of the population from the US, that really opens up questions about how that's affecting patients in the United States. So these are some remaining questions, and this is from our review article. Do vaccinations provide a clinical benefit in patients with MGUS, smoldering myeloma, or myeloma? And how do we measure the benefit? Is it by survival, hospitalizations, cost reduction, other endpoints? And if there's a clinical benefit that exists, what are the surrogate markers? In many of the studies I looked at, they were looking at arbitrary thresholds for IG subclass response and something called opsonization or functional assays, but as far as I could tell, had not been validated for clinical endpoints, at least in myeloma. And should we include something like an immunological dashboard followed sequentially in addition to myeloma tumor burden markers? And I think some companies have looked at that, like Tempus and Adaptive with Microsoft, trying to look over time at the immune function of patients besides just their M spike and bone markers and things like that. How should we vaccinate? Should we adaptively according to surrogate marker? And now you can get antibody markers, but we don't know if that's a threshold, is it an area under the curve? What do you look at? And we think for COVID that the antibodies do appear to correlate with functional assays, so that's good, at least outside of the cancer setting. And do we do double or quadruple dosing patients? There are some studies starting to look at some of those things. What is the evolution in immune function from MGUS to myeloma? I think we know that partly at least. It gets worse over time. However, that is very variable when you look at the status of disease and what people are being treated with. So is an IMiD the same as a proteasome inhibitor, the same as XPO inhibitor, et cetera? What is the best time to vaccinate patients with myeloma? Before induction, after consolidation, during maintenance, after maintenance? Should novel strategies be tried, like less aggressive therapy with co-measurement of cancer response and immune response, if many people are still dying in induction? Does maintenance with an IMiD or proteasome inhibitor result in improved immune function during maintenance? Does the minimal residual disease status relate to the vaccine response? And can you give live vaccines, and when? And part of live vaccines is potentially for travel to various areas of the world where you still need live vaccines. So this is looking at influenza vaccination in plasma cell dyscrasias with 180 patients and looking at 1 versus 3 flu shots. And they have PCV13, which is pneumococcal vaccine. Started in October 2019 by Craig Hoffmeister at Emory. That's his Twitter handle. And it's on clinicaltrials.gov if people want to look it up. But I think these are the type of studies we need to look at some of this very basic information for the #1 cause of death and a major cause of healthcare costs and morbidity for myeloma patients. So this is a really nice study. I don't know the status of it, and it may have gotten disrupted during COVID. So remember your vaccines. There's a lot of people talking about not as much now, I think, but earlier in the pandemic, that cancer screenings were down, vaccinations were down, including for kids. But for myeloma patients, I think all over the country, and not every single place, but a lot of people are pushing people out and trying to see them virtually, maybe giving them chemo holidays, sometimes switching from injectables to oral drugs and things like that. And we're having less contact with patients. I'll kind of end my conclusions later by saying that I think we basically should treat people aggressively with myeloma, including transplant, especially now that the vaccination rates are so high. But there's emerging data that even though you can have a lot of problems if you get COVID with myeloma, you can also have problems if your disease is progressive. So we'll talk about COVID-19 and myeloma. In my own clinic, this comes up more so even than the anti-cancer therapy. People are very, very interested in this. And yesterday when I was in clinic, a bunch of people told me about their vaccine status. And I think people are very excited now that they're getting vaccinated However, we don't know, what the antibody response rate is in cancer patients. We'll have that eventually. There are some studies looking at that, but not enough really. So there are registries. I mentioned some earlier, but Adaptive is the company that does MRD testing for myeloma and other cancers. The COVID Cancer Consortium, in which I'm on the steering committee for, ASCO, ASH, CIBMTR, which is the Bone Marrow Transplant Group, International Myeloma Society, MMRF, the National Cancer Institute, Tempus, which is a precision medicine company, and many others. There are a limited N, so a limited number of patients where we can do multivariate analysis. So I was just on this conference call with Sam Rubenstein, and we were looking at numbers for overall hematologic malignancies, and then looking at the myeloma numbers. And then as you start looking at, like, let's say you wanted to look at IMiDs versus proteasome inhibitors versus other drugs, you start getting down to smaller and smaller numbers, where even you might be seeing differences, you can't control for other factors. So for instance, people getting quadruplet therapy may have worse disease, and it's not because they're getting quadruplet therapy that they die of COVID, but because their disease is progressing rapidly, et cetera. And some drugs that have been used in cancer, such as selinexor as a myeloma treatment, or BTK inhibitors such as ibrutinib or acalabrutinib, have been used in various clinical trials as potential therapy for non-cancer patients with COVID-19. I haven't really seen a lot for signal on that, and it's been a while. I think if they were blockbusters, we might have heard by now, but there might be something more subtle that we're waiting on. So for cancer, the consortium that I'm part of, the CCC19, has been active since March of 2020, so very early on. We started collecting retrospective data on patients, and the first publication was in The Lancet, where we had about 1,000 patients. The second publication was in Cancer Discovery in late summer, where we had over 2,000 patients. And then just recently, a few weeks ago, Dr. Grivas and colleagues, including me, published our newest data with nearly 5,000 patients. So we are getting some information, even though this isn't a randomized trial, we're collecting information. So early on, there was data from New York City, and they looked at 218 patients, and this is in the spring, and they looked at the case fatality rates for myeloma. And so these were patients that were in New York during a peak capacity in many of the healthcare systems, and the myeloma numbers were fairly small to look at, but still case fatality rate of about 28%. This was subsequently looked at in our data set, and this is very early on. So the numbers changed over time, and I'll show a graph of that. So that you can see for thyroid cancer, again, small numbers, low numbers, breast cancer 6%, myeloma 7%, the overall cohort 13%, but this is early numbers, and then some of the other ones. But lymphoma and lung cancer have been and still are some of the highest risk diseases for cancer. So we worked with a company called SciAps, looking at real-world data with a software platform for COVID-19 across multiple health systems. And Brian Rinne, who was one of the leaders of the NCI study, talked about our CCC19 data fairly early on at the AACR COVID meeting. And we saw over time that the numbers, as we got larger numbers, the myeloma numbers got closer to 19%. This is at AACR in July. So in August, Dr. Sam Rubenstein, who was at Vanderbilt, now at UNC, looked at 39 myeloma patients, so still low numbers, but found worse outcomes than both the general population with COVID-19 and with other patients with heme malignancies and COVID-19. And the high mortality may be showing the need for aggressive infection prevention strategies, and we talked about vaccination and before we had vaccines. This is from a little bit later on. So ESMO is a European meeting in September, and we were updating our information then. So since then, we had a couple things in the fall, and then in December 2020, we had updated data both on blood clotting and on COVID infections in hematologic malignancy patients, and that's again from Sam Rubenstein, was the first author. Here's from that abstract 1632. There were over 700 hematologic malignancy patients. 167 were myeloma. So at the time, that was a very large number for looking at myeloma data. And you can see in the table where I've highlighted the plasma cell dyscrasias, or myeloma mainly, 167 patients, and the 30-day mortality was 19%. And then we looked at very early data with small numbers, repurposing COVID-19 therapies such as JAK inhibitors, which are largely used to treat MPNs, BTK inhibitors, often used to treat lymphoma or CLL, and BCR-ABL inhibitors used for treating CML. And we have a manuscript in preparation with a larger number, and we'll be doing subset analyses of various treatments and hematologic cancer types. So this is a summary as of February. I don't think there's any updates, but the first report of the case fatality rate. So there's other things we can look at. We can look at infection rate, we can look at severity rate, hospitalization rate. Many of those things varied over time based on hospital capacity, based on understanding the disease, other things. And there is a shift in decreasing mortality over time as people got smarter about things, and we ramped up capabilities. But the case fatality rate was reported in Wisconsin by Bernard DeCall with 7 patients with a 57% case fatality rate. So that was not good. And then in New York, there were early numbers. This was at their peak capacity, and when they were spiking 38%. And then there was other data from other parts of the country, Spain, Italy, with numbers in the 30s. So this was looking not good. And then updated data from New York with a little bit larger numbers. The numbers were in the 20s, low to high 20s. And with including, but these are mainly admitted patients. In our first study, we had short follow-up and small numbers and said 7%. That was probably just an artifact of small numbers. In the UK is around 50%, and similar between newly diagnosed and relapsed refractory patients. It's kind of interesting differentiator there. And then throughout the summer, we're saying around back to that 19% number. In Latin America, 33%, and then ASH, we went back to 19%. And then the ASH Research Consortium, which is the Wood et al. Blood article, is 116 patients, mainly US, but some international, showing 19%. So, between our CCC19 data and the ASH RC data, it looked like around 20%. And so I really was worried about my patients a lot then. We have a preprint looking at convalescent plasma use, and convalescent plasma looks helpful in myeloma patients, but those that got convalescent plasma that were hospitalized, 9% died versus 13.5% that did not get it. And this is an update from something I talked about on Monday to the National COVID Cohort Collaborative. And we already talked about, heme malignancy patients potentially doing worse, and increased mortality and other complications. And there have been a number of studies looking at that. Convalescent plasma is the blood product people after they've had infection. And there have been studies looking at this through emergency use authorization in open label as well as randomized clinical trials with mixed results. However, early convalescent plasma use seems to be beneficial. And the FDA updated the emergency use authorization for COVID-19 convalescent plasma to reflect new data, including data they looked at of ours, which showed that you want a high titer antibodies. So a lot of antibodies in your convalescent plasma. That makes sense. The dose is important. Early dosing, which also a lot of people thought if you give it very late when you already have an inflammatory response, it's too late. and to consider use in hospitalized patients who have impaired humoral immunity and cannot produce an adequate antibody response. So who does this sound like? This sounds like myeloma patients. So the FDA is giving guidance. So if you are at your facility and someone says, oh, it's not our policy to give it, you say, here's the FDA guidance. They updated it in February. And so I've pushed for that because our policy was not to use it, especially later lines of use. I'll show you some information about that. So here's some more preprint. We looked at 30-day mortality. So that's a hard endpoint as opposed to things like hospitalization, length of stay, and oxygen use, other things. We looked at mechanical ventilation ICU admissions and how those people did. We did something called propensity score matching, which is trying to control for variables. So this is not a randomized trial, but as much as we can, we're trying to control for things that might get in the way of clouding how we're looking at things. And this is the multi-center CCC19 registry. Patients with heme malignancies were hospitalized due to COVID, and this is from March through January of this year. Convalescent plasma is anytime during hospitalization. So 30-day mortality, we adjusted for potential confounders. So we already talked about that. This is like a statistical thing I won't go through because I can't explain it that well. So we found, this is not a Kaplan-Meier curve exactly, but looked at overall survival on the y-axis versus days on the x-axis. And you can see that the patients with convalescent plasma did better. The top is overall and the bottom is propensity score matched population. So trying to control as much as we can in a registry for other variables. So this is available. It's a preprint. Anyone can download it. It's from it's from medRxiv, and it's been submitted for peer review in a large journal. So
Thompson, I'm a little concerned about us getting to questions. So
okay,
what you're doing is great, but I just want to make sure we get to a few questions as well.
sure. I'll end this soon. So this is a very complicated thing, but I highlighted the hazard ratio for the overall population, intensive care, mechanical ventilation are all good. So below 0 is, or below 1 is good. But the people in the ICU and the mechanic and on the ventilator actually did better, which is different than the dogma for everything else that we've done and how hospitals are operating. So for people with heme malignancy, they might do well even if they get convalescent plasma late in the game. And this is Dr. Joyner at Mayo really helped push some of these discussions. He's in charge of the expanded access use for the entire country, 105,000 patients treated. There are some more data that confirm what we have found. So Dr. Clausen in a Mayo Clinic Proceedings article, and then Dr. Sennefeld had another article too. And then people that have had prior COVID infection and then get vaccinated have higher antibody levels. This might be really important for myeloma patients. So if you've already had COVID and thinking about maybe you need the vaccine or not, this may really give you a huge boost in your antibody levels. And more information is needed on this, but this is we've been thinking about using this as a therapeutic strategy. So conclusions, vaccinate. We don't know what's important, antibody response, and how that correlates with functional response in myeloma patients. We have a population level data of benefit around the world. The US may be different for some reasons we talked about. I would avoid live vaccines, and then the zoster vaccination as of unclear utility to me at least. The prophylaxis viral, I say yes. The bacterial and PJP, I'd say talk to your physician. And use universal and COVID-19 precautions as everyone does. If you're admitted to the hospital with a severe infection with COVID, I would ask for convalescent plasma. The data is somewhat limited, but I think it's enough for me. I've done it on my patients. And then for COVID-19, there's no clear dosing on the type of vaccine, dosing, antibody or T cell testing afterwards, duration, viral perseverance, et cetera. I encourage all my patients to get it, and I don't hold chemo for vaccinations, but different doctors think different things on this. And treating and controlling myeloma is important, even with the infectious disease risks. Thank you.
Fantastic. What I'm hearing you say is, I'm glad you went over all the other vaccinations at the beginning because, COVID's not our only concern, right? I mean, the flu or pneumonia or these other things we interact with every day are equally concerning to us as myeloma patients. So thank you so much. Very, very informative. So I want to jump to Q&A, and there are some very practical questions. Like Adrian's asking, if you're currently undergoing immunotherapy using a BITE or a bispecific antibody, is there a reason not to get the COVID vaccine?
This is something where I don't think there's any data. If there is data, it's probably going to be in less than 10 patients, so very anecdotal. I don't know of a reason, but I would talk to whoever's giving you the BITE. I would talk to them. There might be on study reasons. Most studies we have open have had amendments for COVID that have changed things. So there might be some issues with various clinical trials or with various protocols at institutions, but there's no reason I know of.
Okay. You mentioned levofloxacin prior, and that there was kind of some indication that it had better benefit, earlier, and then now maybe not so sure. Michelle's asking, there's so much negative information about this antibiotic regarding muscle damage. Are there other safer antibiotics that could be given instead? It seems like it's kind of a go-to for dangerous infections.
Yeah, so levofloxacin, like when I was in residency, I was like the antibiotic because it covers gram positive, gram negative. It's usually very well tolerated. So it's good for treating pneumonia, atypical pneumonia. It's not really muscle damage; it's the Achilles tendon which can rupture. So your gastrocnemius can be displaced. So it's I don't know about other muscle than that, but I mean that's a problem, right? And if you're young and active, if you run, you're doing something, no one wants that. So I have not really been using it, and I have not been prophylaxing either with Bactrim or with levofloxacin in all patients. And when I brought it up in the US, people have been less excited. We did a Twitter chat on it a while ago with some of the UK people. So I think more data is needed. In general, for patients with myeloma or other cancers, I use Augmentin a lot. And if they have infection, I would tend to use Augmentin and Cipro, which has the same problems. It's just a different antibiotic. It's called a fluoroquinolone. So I think that data that's not nailed down, even though they did a large randomized study that was really well done, good p-values. It hasn't really, I don't think, influenced behavior that much in the US.
Interesting. Okay, another attendee is saying, I'm an elementary school teacher, had a stem cell transplant early February 2021. Teaching virtually, is it safe to return to face-to-face teaching in August? And what vaccines are necessary for this person to have before they return to work, scheduled to start school next fall during the first week of August, which is closer than you think.
Yeah.
Yeah.
Well, hopefully, number one is after a transplant, you're going to have all of your vaccinations again, I think is the usual protocol. I'm not a transplanter, so I don't know it off the top of my head, but we have a protocol. We just click, it's an order set in Epic, and people get all the vaccines spaced out. So you should be vaccinated. So you'll need, if you had your COVID vaccine, you'll need to redo that. As a teacher, you should definitely get it. By August, I don't know. I mean, like if I was you really need to individualize it with your doctor. But if I was your doctor, I would look at your white blood cell count. I'd look at your immunoglobulin level to look at the recovery. It also depends on the case rate in the US. If the case rate in the US is very low, I think your risk will be low. I mean, you can still get other things, right? You can get RSV, you can get influenza, you can get bacterial infections, just the usual stuff, right? Kids coughing on you. So I would consider wearing a mask. I think a lot more people in America are going to wear masks compared to like in Asia, especially if you flew internationally. Lots of people were wearing them before all of this, right?
Mm-hmm.
And we've seen, you guys know the data that for kids with RSV infection or adults with influenza, the numbers have just been dropped down so far. So doing all this stuff helps with all sorts of other infections. So I think for people that are constantly immunocompromised or don't know their status, I think it's going to be important to use more than the usual precautions. And it's not gloves, right? It's alcohol, hand washing, or soap and water washing, masks, and distancing from sick people. So that's kind of, some of those were universal precautions. But as a teacher, yeah, I mean, I would, before August, I would definitely meet with your oncologist and have them run a battery of tests. Now, I have been tempted to get, antibody and T cell testing from like Adaptive. I think you have to pay out of pocket like $150, but we don't know what it means, right? So if you don't have an antibody response, presumably that's not good. It doesn't mean for sure that you won't be covered. But back when I was in residency, I didn't have an antibody response to the hepatitis vaccine and I got redosed. So I would love to see a national effort to look at cancer patients of all types. And if they don't have an antibody response, think about redosing them or things. And then we don't know, do you use the same vaccine? Do you use the different one? Is there different dosings? All sorts of those things. We don't know, but I would be hesitant if your immunoglobulin, your IgG was below 500 and your white cell count was still low out then, I would be, worried about things.
Mm-hmm. Yeah, Cindy in the chat is saying she got vaccinated for the COVID vaccine, but testing shows she didn't get any antibodies from it. And the myeloma specialist is just kind of saying that was to be expected.
Well, I don't know if I'd say it's expected. So I think we've seen various antibody responses, like from the pneumococcal vaccine, but about 50%. That was the study from like 1994. So I think I would expect it to be less, but I don't know. A lot of those studies, like if you're on melphalan and dexamethasone, how does that compare to Revlimid? Like, I don't know. Some people think that the IMiDs such as Revlimid actually improve antibody response.
Mm-hmm.
I mean, there's limited data for that, but I mean, that's where I would be awesome to have, and that's where you could do that on a clinical trial. And I think we will have data years out where we have people on, let's say, Dara, Velcade, plus or minus venetoclax, and you look at both arms, you look at COVID, and maybe you can check some of those correlatives, right? I mean, we'll be able to get that eventually, but right now, I don't know what to expect. I would expect probably a lower antibody response, but in an individual patient, you're either going to respond or not respond, although it is a continuous variable.
Yeah, we don't know, so you should still plan on getting it, right? So it depends, like what you're saying, what you're on. So Carol's saying she's 9 months post-transplant. She had COVID December 2020, received the monoclonal antibody treatment for COVID. What do you suggest as far as getting the COVID vaccine? How soon do you get it? This is a very common question that we get all the time. If I'm planning for transplant, when do I get the vaccine? And same thing for CAR T. Like if I'm going to go through CAR T therapy, how soon after that should I get the COVID vaccine?
Yeah, I think there is guidance from the, they've renamed it like ASCTC. And I don't know if it was Miguel Perales from Memorial. I might be thinking of someone else, but I think they did give some guidance. And after transplant, I think it was out like 100 days, and various institutions have varied somewhat. But I would definitely get the vaccine. And then the timing of that is probably going to be based on your transplant center. I think early on, people like, let's say my neighbors who got COVID and then they weren't so-called, allowed or suggested to get vaccinated until 3 months out. I think that's because we didn't know how long the antibody response lasted in normal individuals, and presumed, like based on prioritizing and access, we should, like, the people that were recently infected are probably safe for a few months. I think there's data, Eric Topol has shared, that it's probably much longer in the average person. Now, in lymphoma, myeloma, leukemia patients, is the persistence of the antibody going to be as long? I think it's going to depend more on not your diagnosis, but your state of disease. So if you had a stem cell transplant 10 years ago and you're on no therapy, you're going to be very close to a normal individual, I think. If you have on 10th line therapy, you've gotten bendamustine and your bone marrow has been beat up over 20 years, yeah, you're probably not going to do as good for any vaccination, right? The problem is we just have limited data, even for stuff we've had for pneumococcal and flu vaccines. We just don't have that much robust data in myeloma. We have it, and it's not even necessarily even that robust in the general population, but for sure in people that have gotten different therapies. So I think the bottom line is get it when you can, and watch the literature. And it could be, there's this variant that I think is the most common variant spreading in states where it's going up. the B1117, I think, variant. That and other variants, as they can flip out these RNA vaccines fast. It could be in the fall that everyone gets a booster with a new variant, or you get a cocktail of 5 different variants that, like, just like PCV13 is 3 valencies for pneumococcal, or PPV 23 is 23 types of pneumococcal vaccine. We might be getting things like that, cocktails of things, but it's largely a black box.
Yeah, yeah, interesting. Okay, so someone is saying my brother, who's had myeloma for over 30 years, is getting Dara-Velcade Dex every week. Had a severe reaction the first treatment in February, and they kind of restarted, and now tolerates it. So this is kind of an interesting question because it probably is not related to COVID, but for patients to know, like, is it safe for him to get a COVID vaccine? People are saying, gosh, if you have severe reactions to other kind of vaccinations, or you have severe allergies or something like that, it's probably unrelated, right? But
yeah, I think so. So when I got mine, they made us sit for 15 minutes, or if you've ever had a anaphylaxis, which I have, not to a vaccine, but to, well, you don't need to know that, but I've had anaphylaxis, and so they wanted me to wait 30 minutes, and the person was hesitant to even give me the vaccine. I'm just like, I'm here, just give it. Especially the RNA vaccines, there's very few components to that. So there's no egg or anything like that. So with daratumumab, having the first time infusion reaction or reaction, even if it's subcutaneous, is pretty common, right? So I wouldn't see that as it'd be like rituximab is very common. 25% of people have a reaction. So, and even with the pre-meds, and, Saad Usmani's got a pre-med regimen and stuff like that, and UPenn is given a pre-med regimen. So I would not hesitate. I would, there's different ways you can get the vaccine at my site. It's an auditorium, and they have you go sit there, and there's lots of nurses and stuff. Some places it's a drive up, they do it, and you're supposed to sit in your car. I'd probably have someone with you if you've had something and you're worried, but I think that's probably good to have anyways.
Okay, Ron is asking a question from kind of the beginning of your discussion. Do you recommend a yearly pneumococcal vaccine for myeloma patients?
I haven't been doing that. And, I think probably the flu vaccine, especially because it varies, is going to be more important. I think actual pneumococcal pneumonia as a cause of hospitalization or death in myeloma is pretty low in the US, I think. And there probably is some herd immunity for all the people that have gotten. I mean, that's a kind of a primary care doctor. They push for vaccinations. And so that's probably protecting a lot of myeloma patients in the US. That would be a good research study, but I wouldn't do it off of a clinical trial.
Okay, Elsie is asking a very practical question. After over a year of being isolated, if someone is fully vaccinated, can they gather with other vaccinated people outside of the household as per these new CDC guidelines, or should she still stay in her lonely bubble? That makes me sad to hear that, but it's true. It's been a lonely bubble for people.
Yeah, I think we're all crazy and cooped up. And I think not only for patients, but for like me, I've been trying to be as conscientious as possible. And just this last weekend, I went to my relatives out of state because just about everyone had been vaccinated. And so I felt comfortable doing that now. If you are in, your disease is still very active and you've been vaccinated, I would be more hesitant. So I think it depends. It's going to be a little bit variable, but if your disease is not active, you're on minimal therapies, you're well controlled, you're stable, and everyone you're seeing has been vaccinated, I think it's fairly safe. I think and this is fairly new information, we think the people that have been vaccinated, their chance of transmitting it is fairly low, right? So even if they get it and they're asymptomatic, we think the transmissibility is low, which is what I was very worried about, that I could have it, not know it, and give it to my myeloma patient. So I think it's fairly safe. It's kind of there's not going to be a black or white number on that, but I would still, even before COVID, I would say use universal precautions. So I tell myeloma patients it's probably not the time to be a church greeter or run for politics and shake hands or all sorts of be the Walmart greeter or stuff like that. Like you probably want to have some offsetness. But I think if you're vaccinated, the people you're with are vaccinated, I think that's about as safe as it's going to be for a while.
Mm-hmm.
And it's going to be an individual risk calculation, but I think it's probably going to be okay.
Mm-hmm. Okay, I might take a couple minutes to go a little bit over, unless you have a super
No,
hard
that's
stop
okay.
in a minute.
That's
Okay. Another patient is mentioning that, and this may be important for the other person who said this person's on RVD plus DARE and had an antibody test a month after the second dose, which was, not there. And then a month later, an oncologist ordered an antibody test and showed a high level of antibodies. So maybe some of these COVID antibodies can grow over time. I don't know.
Yeah.
Right?
And I forget the publication that was in, but yeah, I'm trying to think of which one it was. I think it was one of the mRNA. Well, I can't remember. One of the vaccines, they did show that antibody response did increase over time.
Mm-hmm.
So that is very promising, right? So that, ideally, right, we would be able to have sequential B cell like antibody response and T cell data to follow over time, and we'd know what that means. So even if you don't have, so number one, you got to check the right antibody, right? So you got there's lots of different tests, but you have to check the antibody that's appropriate for after vaccination. Look for vaccination response, right?
Mm-hmm.
So you need that. And then it is possible, like let's say you are immunocompromised, it may take your body longer to respond than I think in the studies where the curves diverge is kind of like after 14, 15 days or so, show it for people that got COVID versus didn't after vaccination versus placebo. So I think that's promising. I'm still tempted to check myself and see what's happened with me, but
Yeah, I know, right?
but, what do you do with it? Like then, or you feel guilty if you think I don't know. It's hard. It's hard.
Well, another very practical question, possibly preparing for a transplant. I would add CAR T or bispecific antibodies to this, or other things that are immunotherapy related. Is it worth getting the COVID vaccine if you're headed into transplant or CAR T?
Yeah. So I think it's hard to know. So number one is if you get the COVID vaccine, we are seeing patients that have ipsilateral, so same side, axillary or armpit lymph nodes can swell up. Mm-hmm. And we've seen that as when women are getting a mammogram after their COVID vaccine. Mm-hmm. And then sometimes on imaging or PET scans or CT, you can see the lymph nodes that grow. So there's something about that. But and I don't know if there's any data on stem cell collection or CAR T production that has anything to do with that. Maybe someone knows that. I don't know that. So definitely it's going to be.
But this is pointless. Like, is it pointless to go get it if it's just going to be all wiped out with that treatment? Like,
yeah. So I think again, is Miguel Perales at Memorial that showed that some people that got vaccinated did still have antibodies after transplant. So there might still be some persistence. I would be tempted to, just because during like an auto transplant, you have a window of being immunocompromised, and even though it won't be perfect, it might be something. And I mean, I would be tempted to still get it, knowing that you're gonna get it again. Now, if it's going to be in like 2 weeks, yeah, it's probably not worth it then, because stuff's going to happen so fast, and you're going to have the melphalan so soon. So it probably depends on the timing. Again, we don't really know the data, but that's my kind of gestalt is I would do whatever I can, even if the response rate is low. If it works for you, that might give you a little bit of benefit. There are multiple people looking at passive immunity. So giving various forms of convalescent plasma or the super duper convalescent plasma. The blood group at Mayo is looking at this, or the blood bank at Mayo is before transplant prophylaxing people with COVID convalescent plasma.
Wow.
And that's fairly cheap, I think, and widely available throughout the world, right? Versus the antibodies, which I think are very expensive and I think still somewhat limited. There have been some other strategies, including transgenic animals producing polyvalent antibodies against COVID. And I think that still may have a role unless COVID goes to zero, which I think it's going to be still probably prevalent for many years, if not forever. So for people that are getting transplanted, there still might be a role for various COVID prophylaxis regimens. So I think people are thinking about those studies.
Okay, we'll do two more questions. And sorry to keep you over, but
Sorry.
this is such an important topic. Okay, Dobie's asking that my specialist recommended getting a COVID antibody test 4 weeks after my second vaccine. Do you recommend that? Like when should these antibody tests? And by the way, which are the best antibody tests?
Yeah. Yeah. So I think there's no like national guidance or there's no data saying what to do based on that. Like I said, I'm interested. I haven't done it for myself or I haven't done it for my patients, but if someone wanted it, I would order it and do it. I would discuss with them, like, let's say it comes back negative. What are we going to do? Like, can we just keep giving you, vaccines?
Mm-hmm.
I do suspect that, you're getting benefit. I think it was around like 70 or 80% benefit after the first vaccine and over 90% after the second for the two vaccine types. Now, not all of that may be measurable in the antibody. The specific antibody you're measuring, it might be T cell response and other things. So, I mean, if your oncologist wants to do it, I wouldn't have any reason not to. I just don't think it's something we can tell people they need to do or they have to do because we're not really sure what to do with it yet.
Mm-hmm. Okay, there's another question from I'm not going to say the name right. So, Neom. So, do you recommend a specific COVID vaccine or just take the first one we're offered? I've gotten this a lot from European patients or patients in other countries. Is the AstraZeneca vaccine because that's really what's all available over there
Yep.
currently. So that's just I've gotten that question so many times. I'm going to ask that.
Yeah, I would get the first one available. And I think that's if you follow Vincent Rajkumar on Twitter, and his wife is infectious disease doctor, so he's pretty good for the overlap of myeloma and infection, right? I would get the first available because even if it's slightly less effective, and these are not head-to-head studies, right? These are different studies, so it's all the cross-trial comparison caveats. It's probably going to be better than nothing, and in the fall or whatever, there might be new vaccines available and we'll have more data, but I would get whatever I could at the time.
Mm-hmm. Okay. And the last is comment. I guess Steve kind of had this question. Are we or some other organization collecting data from myeloma patients who've gotten the COVID vaccine to document side effects or reactions? And we have this part 2 study that's open. If we're not asking those questions in that, which I think we are, then we could do that in a part 3. But the last question is, you were one of the first researchers to really utilize the HealthTree Cure Hub portal to facilitate your research. And I just want to ask you, as a researcher, what that process was like for you and why it could be helpful to you.
Yeah, I mean, as you know, I'm the rate limiting step in that project.
Oh, that's
So
okay.
anytime I work with you guys are very fast, efficient, and thoughtful. But I think it was very interesting because a lot of the correlates, it correlated with the data I had in my own institution and that now we have internationally. So when people say, oh yeah, everyone does this is perfect. And you're like, I know probably some of the people in that cohort may have seen you, right? That we know, and those are the people that are online in your study. Those are very advanced patients generally, right? They're not the average person. And so if they're either not sure about, we looked at other things like radiology, cytogenetics and stuff. If they're not sure about some of those things or got something that wasn't optimal, that the rest of the iceberg that we're not seeing, is probably even worse. So it's a type of real world data, which I think is not the same as a randomized trial, but it definitely can be confirmatory, hypothesis generating, and it can serve lots of functions, right? It can educate people. It can take, like, maybe I have an idea how things work. I look it up like, oh, that's not what we're seeing. Why is that? Is there a problem with the sampling, or am I just completely off base? And I think the type of stuff you guys are doing will be great preliminary data for clinical trials and for grant submissions, all sorts of things that people can work on. And I can, we had so many ideas, like you only do so many at once, but this is one way you can do something fairly fast, easy, and with people that are motivated, that trying to write a grant for it or something, or, get NIH dollars would be overly prohibitive. So it's been really good. And like I said, there's caveats, right? It's not a randomized trial, so it's got to be seen as hypothesis generating.
Well, we so appreciate you joining us today. It's a perfect way to launch this immunotherapy chapter, and super helpful about COVID-19 vaccine, but also so important that you talk so much about the pneumonia and the flu vaccines, because like you said before, we do have a lot to think about. It's been a crazy time, as we all know, and it's nice to get some answers about how COVID is affecting our myeloma population. So we appreciate you mentioning so many of the studies that are being done. And with that, I will thank you and turn the time back over to Audrey for our closing announcements.
Thank you all. Thanks for inviting me.
Thank you, Dr. Thompson. We really appreciate you. Okay. Quickly. All right. Our next immunotherapy treatment chapter event will be in early May. We are still working to coordinate schedules with our speaker, so the date is to be determined, but we will be talking about Blenrep and how it's being used in the clinic. You might be interested in other upcoming events that we have in the myeloma crowd community. Tonight, April 7th at 7 p.m. Eastern is our Fitness for Myeloma chapter event. We will be discussing the benefits of fitness for myeloma patients with multiple myeloma specialist Dr. Jens and Michaela Hillengas. We're going to be talking about early data about how fitness affects myeloma patients and also sharing practical exercises for staying fit at home. Saturday, April 10th at noon Eastern is our Myeloma Crowd Roundtable, where Jenny mentioned this at the beginning of our discussion. So it's going to be about BCMA and other targets in myeloma therapy. We hope you can make it. On Tuesday, April 13th at 6:30 p.m., that should say PDT, but anyway, it doesn't matter, Pacific time, is our SoCal Community Myeloma chapter. We're going to be talking about the second step in the Cure in 5 initiative, how to build and grow our myeloma communities. And then Thursday, April 15th at 7 p.m. Eastern is the Myeloma Caregivers chapter. We're going to be talking about financial resources for the caregivers. And we have myeloma financial coach Diana Valentine joining us for that event. Special thanks to our community event sponsors, Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. And thank you again, Dr. Thompson, and thank you all of you for attending and helping us grow our myeloma crowd community. We appreciate you and hope that you have a wonderful night. Thank you.
Thank you, Dr. Thompson. Appreciate you.